All right. Well, good evening, everyone. I
From
think
Gary.
we'll get started. Are you missing someone? Or you got who you want here?
Yeah,
Okay.
yeah.
So, good evening, everybody. This is I don't know how many we've done of these Mavens in Our Midst series. This could be maybe the 10th or something like that. We've found that to be a really good way to kind of highlight some of our members during this pandemic while we're all at home. And so many of our members have expertise in various areas. And this is our first repeat guest maven because it's so timely what Steve's area of expertise is. So I want to introduce to you Dr. Stephen Schwimmer, who I think most of you know. He has been a member of Beth Hillel for decades. I don't know exactly how long.
About 1990.
Okay, that qualifies as decades,
Mm-hmm.
30 plus years.
Mm-hmm.
And he is an infectious disease physician and really has his finger on the pulse of what's going on. He's a key member of our COVID team at the temple, and just we really relied on him during these last 9 months. So we asked Steve this time to talk about the vaccine and how we might expect that will roll out and if affect us, and also how is it going to change how we're living our lives and what can we expect in 2021. So Steve, take it away.
Okay, thank you. I wasn't planning to limit it to to the vaccine. What I'm going to talk about are issues that are relevant to the vaccine, but I wanted to start out with this. An example of how public health in the United States can work. And the example is tuberculosis. Tuberculosis until last year was the biggest infectious disease killer worldwide, with about 1.5 million deaths a year. But in the United States, we have, I gotta move this, okay, had just a tremendous decrease over time, over decades, in the amount of TB in the United States. And we do this, and so in 2019, there were only 8,900 TB cases, and it's been going down, but here's the deaths from TB. So in the United States, as opposed to 1.5 million deaths a year worldwide, we have less than 1,000. And we do this this is purely public health. This is one of the key duties that public health agencies throughout the United States do. It's their responsibility to find these patients, find their contacts, find the people who have what was called latent TB. And approximately 1 out of every 4 people on the planet carries this bacteria. Roughly 13 million people in the United States carry this bacteria. And by doing surveillance and case finding and contact tracing, in the United States, we have these incredibly low rates, which are as low as just about anywhere in the world. And there are countries that literally have 100 times the rate of TB that the United States does. So there is very unevenly analogous case finding and contact tracing for COVID. I asked my friend Gary Hauptman, who has been doing contact tracing for Arlington, Virginia for about 10 months now, to come on and talk and describe from his point of view of experience how this is executed for COVID in a highly functioning program. Okay, Gary, have you unmuted yourself?
I am now. It should be able to.
Okay. All right. So, um, tell us about your job.
Well, it's not nearly as much fun as my usual job with the county, but
Mhm.
it's what I've been doing for 10 months. And I started out doing initial contact interviews with people who had recently been diagnosed from testing as being COVID positive. They would be routed to us through the Department of Health, the Virginia Department of Health, and there would be a 45 minutes to as much as an hour and a half of interview, getting the kinds of details that we need, such as who their contacts were and how are we going to get a hold of them. As well as getting a briefing on all of the symptoms that they may or may not be experiencing. After doing that for about a month, I moved over to another department, which is referred to as active monitoring. And that's where the daily tracing takes place. You are probably aware of the times, the time that the CDC guidelines set up for what the minimum is, which is generally 10 days from onset of symptoms to that is a minimum for somebody to be released from this monitoring process. And then if you are just a contact that hasn't necessarily been tested positive, it may be the 14-day period. And of course, these can all go longer if somebody is ill and isn't showing signs of no longer being contagious. So what I do now is sit in front of a computer for about 8 hours, 4 days a week, talking to people on a voice over internet setup, and doing the assessment for how they are doing on any day, with about 14 different symptoms that we track. Go ahead, Steve.
Yeah. Okay. So, so when people are identified as having COVID, it is always reported to the health department, and the process starts of contacting the people who are known to be positive and their contacts, and try to execute so that they do self-isolate or self-quarantine. And so that's what is done with TB, with the differences that TB is spread out in many ways and not as acute, but still, in the United States, we don't miss a lot of TB. Here, where the systems are completely overwhelmed. How many people have you actually worked with, Gary?
It's kind of tough to figure out. It's I did an estimate at a few months ago, and at that time I figured it was between 4,000 and 5,000. At this point, it's probably somewhere between 6,000 and 7,000 people. Because a typical day at this point is somewhere between 35 and 45 people that would be responsible for contacting and assessing in a day. That's a lot, because some of these conversations can run a long time. Part of what we do isn't really just assessing, but it's in many cases, if it's necessary, we help provide resources for people that the county has set up, which may be food, access to free testing. Often it's help with their rent, That there's setting up delivery of medication. That we've got a team up with the Arlington Police Department to do drop-offs of meds, and it can take a lot of time to kind of work that, if you know, to work that part of the system. You know, with most people, they're okay. So, but Arlington has a lot of immigrants, heavy on the Hispanics. But I've been talking. When I have to deal with somebody whose first language is not English, often we use a third-party online or a telephone translator system. And I've worked with a lot of interesting languages. Mongolian has come up a lot lately.
Okay. All right. Thanks, Gary. I'm going to talk about the vaccine study. There's been a lot of talk about following the science. And I thought it would be nice to actually take a look at some of the science for the Moderna vaccine and demonstrate a little bit about what it looks like when it's done right. This and the Pfizer studies were done right. And so I'd like to go through this and take a couple of places and take a look. So this is the briefing document that the FDA had for its vaccine committee in last month that led to the approval of the Moderna vaccine. And these are placebo controls, and this is a chart about how the breakdown between the vaccine group and the placebo group are. There's over about 14,000 each group, and you can see 25% 65 and older, ethnic breakdown, racial breakdown, occupational risk, high-risk conditions, which is delineated elsewhere in this document, and age and health risk for severe COVID, breaking down. And here is a listing of the particular risk factors. And you can see, you're looking at these percentages, that the randomization worked very well. There's virtually no difference between the vaccine and placebo groups for this. And this is what a scientist friend of mine would call the money plot, although it's a table, not a plot. And these are vaccine efficacy from 14 days, at least 14 days after the second dose, which is the major primary endpoint. Another primary endpoint is severe COVID. And you can see there were, for the large number of people, a little over 10,000, both groups, there were 5 COVID infections in the vaccine group, 75 in the placebo group. This over here is the 95% confidence interval, which means there's a 95% chance that the real value is between these two values. No cases in the vaccine group for everybody 65 and over, and only a few here. And then when you had it with and without risk, you have the same great numbers. You know, this is real, 93, 95% efficacy. In communities of color, non-Hispanic, and compared to non-Hispanic, Hispanic, African American. Now these numbers get small enough that they don't hit statistical significance. There's just not enough of them. But as time goes on, they keep following some of these. We'll have better data over this. And as far as the money plot as an actual graph, this is phenomenal result. You usually don't get things this good, but it's real. And it's important. Now, also they looked at side effects, and let's see. Yes, these are very busy graphs. I'm not trying to overdo it, but one of the reasons and one of the benefits of doing a placebo-controlled study is you can quantify things much better. And you can see how often things happen in the placebo group as a comparison. So, so the adverse reactions of any grade was 55% in the treatment group and 42% in the placebo group for the first dose, and 79% for the vaccine group, and 36% after dose 2. For grade 3 adverse reactions, after the first shot, there's almost no difference between the shot group and the placebo group. And this will change depending on the study as far as what you find in the placebo group. Here was people who had fatigue for at least 7 days. And in the placebo group, I'm sorry, I misplaced that particular one, but it's the placebo group, it's about half of the vaccine group. So that lets you know that there's a real issue. Technically, we call that a nocebo effect instead of a placebo effect. But this is one of the reasons, one of the benefits of doing a truly randomized blinded trial is you have a much better, and frequently the only way you can get an accurate understanding of the benefit and the upsides and the downsides is to have this kind of standard of comparison and this kind of statistical rigor, right? In doing it. It's not easy to do, especially when you're talking about tens of thousands of people, which is what you need for a vaccine trial. And even with the 30,000 people, there were only, just a few hundred people across the board who actually got sick with COVID in this study, where the average follow-up was a little over 2 months. So, let's see, 43 serious adverse effects. I'm almost done. I know it's a lot, I'm sorry, but I wanted to show people, because people have to talk about, just say, trust the science, but doing the science is hard. This is a list of all of the serious adverse reactions in the trial. And there's 7 in the treatment group and 5 in the placebo group. And not all of them were truly felt to be attributable to the vaccine. So that's that. Now, I do want to talk and make some comparisons here. This is from the Wisconsin Division of Health. For today, 2,700 new cases, 42 deaths. Only about 12, 13,000 people were tested today, but the testing capacity is almost 60,000 people. The percentage positivity is down to 27%. As a point of comparison, national and international recommendations are to consider reopening schools if the positivity rate gets down to 5%. We got problems here. And I seem to have lost one of my pictures. Okay. Now Wisconsin has about 5.8 million people. South Korea has about 40, 50 million people. Wisconsin has over 5,000 deaths. Okay, so yesterday, there were 236,000 cases in the United States with 4,100 deaths in one day. Israel, which has about 9 million people, has had about as many deaths cases as Wisconsin has, at about 500,000. They've had fewer deaths. Here's the curve, epidemic curve for Israel, for cases. Here's the epidemic curve for deaths. This is at 39 7-day moving average, which is what Wisconsin is down to right now. I think that and I think that's where I'm going to stop at this point. I'll open it to questions.
Okay, so folks, there's some folks here on the Zoom who have had COVID. I don't know how many people here already have received a vaccine. Probably not many, but maybe soon. I wonder, I'm just going to start the questioning with, do you know what we can expect, Steve, in terms of speed of delivery of the vaccine? And can you help us understand, once we get the vaccine, can our behavior change and how?
Okay, there's several things we don't know about the vaccine, which are mentioned in the report that I was just referencing. We don't know the duration of immunity. We don't know whether it cuts transmission. We don't have enough numbers to say that it reduces deaths, but it almost certainly does. We also don't know whether the mutations are going to affect the efficacy of the vaccine. Not surprisingly, there's mutations. When you have as many people with as much virus as we have in the world, this is natural selection. And it's not affected by the vaccine yet, but it may affect how well the vaccine works. What we do have is, as I said, this overwhelmingly convincing evidence that these two vaccines work beautifully. And this was done in less than a year. As far as the rollout, that is something that I, as an individual physician, have absolutely no control over, and really can't really say much about how it's being rolled out because it's rolling out all over the place in different ways. However, Pfizer and Moderna have both said that by the end of this year, they expect to have a billion doses. Mr. Biden has his goal of 100 million people getting presumably the first dose of the vaccine within the next 100 days. As of now, I think about 9 million people have been vaccinated. I did have an email from the health department about rolling it out, but it's very confusing. And it looks like the whole vaccine response is going to be federalized very shortly after the inauguration. So I don't know how that's going to work.
Can you tell us, do you know how, once you get one vaccine, your second vaccine, can your life change? Can the precautions we're now taking change? Or
Not yet. Not yet. There's a couple of things. Number one, and this actually happened a little bit in the trial. People who are immune are getting reinfected, and we don't, and like I said, we don't know whether the vaccine will reduce or eliminate transmission. The antibody responses that are measured are IgG antibodies against nucleocapsid, which is not what the vaccine triggers an antibody response for. But even they measure that, and they're not measuring what's called the IgA, which is the secretory type of immunoglobulin that's at the mucosa. We have not whether people who are vaccinated can carry what are colonized and therefore able to transmit, and how effective or efficient that will be. This is one of the things that happens when you do something so quickly. They did it. They found that it works. I think it would be very, very unlikely that it doesn't save lives, because it clearly markedly reduces severe COVID as well as all COVID. But we don't know how long the duration of immunity is. We don't know whether antibodies alone are a good enough marker of immunity, or whether other parts of the immune system, which is incredibly complicated, are able to be protective or not.
So I don't want to monopolize, but just to be clear, so we still have to mask and social distance.
Yes, absolutely.
Even after we've had 2 vaccines.
Yes.
Because we can be carriers.
We don't know that.
We could be, possibly.
And yes, we could be. And also we have these mutant strains, of which there are several, and which are spreading pretty rapidly. And we're not sure whether the vaccine is as effective against those as it is against the strains up to a month ago.
So what if you have both you and your spouse are vaccinated, and you have a couple that you're friends with, and they're both vaccinated? Is it safe for the 4 of those people to get together?
We don't know.
Okay.
We don't know. I mean, they're already talking about, Microsoft and some of the other tech companies are talking about coming up with a digital vaccine passport. We don't know. And one of the things I would like to go back to, as far as the example of TB is concerned, is even under the best scenarios, this isn't going to go away. Hopefully it will get to the point where we can do the proper case finding and contact tracing like we do with TB, and keep it going down and get to the point where the numbers are low enough, as it has been in a number of countries, where they can safely open up. South Korea is a very good example. Even though they are, they are doing more mitigation strategies, that's because their numbers went up to several hundred a day. The United States, it's insane. It's insane. We're already past the combat deaths from any war that the United States has fought in terms of number of dead from COVID. We're probably going to have over 100,000 dead this month. We're already well over 2 million cases this month. Actually, I think it's already 3, and it's only the middle of the month.
Okay, so I'm going to open it up for, you weren't finished? I was just going to.
No, go ahead.
Steve, do you need the screen sharing now, or could we all see?
Yeah, I should get rid of it. Thanks.
Okay, so who else has a question?
There we go. Hi.
I have a question.
Sure.
Kathy.
Okay, so I'm in Illinois, and
Yep.
I don't know if it's going to be the same everywhere, but I've heard on the news the last couple of days that they are going to start not holding back people's second dose so that they can start giving more people their first dose.
Right.
What happens if you need a second dose and it's not available?
They're basically betting that the production will be there in time. I'm not sure I agree with it, but basically, there is a valid argument for doing that, especially since the rollout so far has been so far below expectation.
Correct. So would it be safe to assume that if your second dose is not available when you need it in 21 days or 28 days, depending on which manufacturer it is, do you have to start all over when it becomes available again?
As of now, no. Actually, this came up on a conference call with one of my professional societies, and in the same kind of document that I showed you from Moderna and the Pfizer one, they talked about how the range of second doses was up to 42 days, and that was within the pre-specified interval. So that's as close as I can give you to a fact about how much longer you can go.
Okay. Thank you.
Sure.
So, Steve, this is Alice. How much protection do you get from a single dose of the vaccine? I understand.
The first dose, it varies, but 50% is a reasonable number.
Okay. And then I want to shift the focus to, if you're unfortunate enough to come down with COVID, do you have what are the critical things to keep in mind as you navigate the disease?
Yeah, the first thing is to listen to what your body's telling you. If you're feeling sick, get tested. Okay. The biggest thing, in my opinion, that will get you in trouble is if you're infected and your lungs start getting bad, and then you have to play catch up. So first of all, you need, if you're sick, okay, get tested. All right. If you're tested, listen to what your body's telling you, especially as far as your breathing. One of the things I've been doing for friends who have been exposed or are sick is I happen to have one of those little pulse oximeters that you can get at Walgreens if they're not sold out. And if that drops below 94%, you need to go in, and because you may need the supplemental oxygen so that you don't progress. And people with COVID frequently don't feel as short of breath as they ought to, given the hypoxia, the low oxygen that they have. And of course, low oxygen is very damaging to people. So you want to avoid that situation. And so that's important. Get tested.
Deborah.
Hi, this is Deborah. Given that high rate of positivity right now, I think you said it was 27%.
Right.
Does that mean like 1 in 4 people who's being tested is testing positive?
That's what it means.
Okay. So with that rate of positivity, what is your opinion about school, high school and also college? What is your opinion about that right now?
Okay. It depends on looking back a little bit in some ways. It depends on how good their people, these organizations are set up to monitor and find it. The professional sports leagues have done a very good job. They've also had access to testing capability that most of the country does not have. They have done a very, very good job of enforcing the rules. And even when, with all of this, and testing everybody several times a week, they're still having breakthroughs, but they're getting on top of those. And they're getting people, when people are exposed, they're isolating. When they're sick, they're isolating. And they're followed, and they're not allowed back to work until they can be confident that they're no longer contagious. So if the institution can do that, and if the institution can start out with a low enough level of positivity, or start out with a high enough level of screening so they can find everybody is infected and keep them off work until they're no longer infected, then that is a safe way of doing things. The problem is it's very difficult to do even when you have tremendous resources, and most organizations don't have those resources. We don't have them. The last number I saw, which was several weeks ago, about total daily capacity for testing in the United States was about 9 million tests a day, which sounds like a lot. But we've got 330 million people in the United States. We've got somewhere between 150 and 200 million people who work. The test, that's not enough. Mm-hmm. And you have to have the rules and enforce them. And that a lot of organizations just don't want to do it, and they want to pretend that it doesn't matter.
So just one follow-up. So
Sure.
For my situation personally, my husband and myself and my kids, we all had COVID in March.
Right.
And my husband and I know that we still have antibodies because we've been giving convalescent plasma, and every time we give plasma, they double check for the antibodies because they're using it for therapy for antibodies.
Okay. Right.
So I feel a little sense of security, if you will. I wear my mask. I do everything the same as everybody else, but I have been teaching some classes face-to-face with a mask. All my students have masks. This is a college environment. We have half capacity of our classrooms, so we only have 12 students in a room for 24. We have the 6 feet. We have masks.
Right. The CDC is currently stating, and they may have changed it recently and broadened it, but they were saying if you did have COVID, you can be assumed to be immune for 90 days.
Right, but this is 9 months later.
Than that, but this is a very, very big and very, very hard to answer question, because we don't know what the correlate of immunity is. We don't know whether you even need antibodies to be immune, or whether other parts of the immune system are sufficient to keep you from being infected or from being sick, even if you are infected.
I'm just trying to decide, like everyone else, what is safe, what is dangerous, and I'm just trying not to make a foolish decision about going back to work.
It is clear you are safer having had it. Okay, and were you all sick from it, if I might ask?
Yeah, so our situation, and again, everybody is totally different. It's totally individual. I'll emphasize that.
Yeah.
But my husband was the sickest.
Right.
He was sick for a month out of work,
Right.
and he had the breathing problems. He was not hospitalized, but he was on inhalers and lots of
Yeah.
different
Right.
treatments.
Okay. So having been
And
sick, you had a higher immune response, at least as far as the antibodies, than people who are asymptomatically infected.
yeah, I mean, I had a mild
And the
case.
duration of your antibody response is likely going to be long, but we don't know.
Right,
I
but
would say, so like I'm being general, your risk having had it is less and may be nil, but I can't tell you that.
right. Well,
Definitely.
and like you said, I could still be a carrier, right? So I still don't want to be going to visit my parents and things
If you're
like
wearing
that.
a mask, if you're doing
Yeah.
the social distancing,
Yeah.
that's,
Thank
those are
you.
the things that need to be done. And in addition to that, you have had it, your body has now experienced dealing with it.
Somebody else, a question.
I have another question if someone else doesn't have a question. Can we go back to where you said the pulse oximeter, 94% or less, if it's under 94%, you should go in. And when you say go in, I assume you mean to the hospital. So,
You call, and most healthcare systems have specific clinics for people who have COVID to be evaluated.
okay, because right now, I have a cough that I've had for about 10 days. And yesterday I finally called my doctor and he asked me what my pulse ox was. And I told him that it's fluctuating between 92 and 94. So
Okay.
when you say that if it's under 94 to go in, I have found that if I move my hand, if I use a different finger, if I use a different hand, my pulse ox registers differently. And I'll do it on one finger for 10 seconds.
Absolutely.
And then
It's
on
not
another
perfect.
finger for 10 seconds. And it changes. So at what point, when is it, okay, I gotta go?
If it's not reaching 95%, if it's not reaching 94%, and absolutely if you are feeling short of breath, you need to be evaluated. Okay, these are surprisingly good devices. I mean, they're like $50 at Walgreens, but they're not perfect. By the way, some of the smartphone manufacturers have tried to have this feature. Samsung did a few years ago, and there have been claims that they can do this, but it's not good enough. But they're fidgety. It depends on your circulation. Also depends on what your baseline is. If somebody has underlying lung disease and their baseline saturation is 94%, 92, 93, 90, whatever percent, then the recommendation as far as 94% goes away.
But us know what our baseline is. I mean, none of us have been doing this.
It's legit. But you're saying it will reach 95%. Okay. So I'm saying you go by your peak. Okay. And you'll learn how to use it because there's a learning curve like everything else. Yeah, there's no question that, what you're saying is an issue related to using this as a test. But like I say, you need, you listen to what your body's telling you. You've got a cough. You're getting tested, and then you go from there.
I wasn't tested. The doctor.
Didn't you say you're going to get a test?
No, I did not.
Oh, I'm sorry. I misunderstood.
No,
You've had a cough for 10 days. You should be tested.
My question would be, how would she have gotten it?
I don't know.
I don't leave the house, basically.
And I'm tested twice a week and I'm negative.
Okay. In that case, get tested, and if it's negative, that reassures you, but get tested.
Steve, let's cut to the chase.
Yeah.
How will we know how to get on the list for the shot?
Um,
I signed up at Lake County and at Jewel Osco.
Yeah, but we're
Okay.
Kenosha.
okay. I did not go to the Kenosha County Health site. I got an email about this. If you give me a minute, I think I can find the relevant email.
This is Connie. I got on the Kenosha County website today and they had a spot to register for it.
Good. That's what I was looking for.
Yeah, everybody that's in 1B can register now. And
Yeah.
it said it was 65 and older for the age group.
Yeah.
The same in Illinois in Lake County.
Okay.
Okay. Let's see if I can get to this screen. Okay. This is dated yesterday from Kenosha County. So, and so there's 4 different ones.
What?
Oh, they're asking me not to forward these links onto anyone, just for 1A eligible employees. And this is as of yesterday. So, sorry.
But Connie's saying 1B you can do now at the county website.
Yeah, like I said, this is yesterday. They may have put that up on the website today. And like I say, next week it's going to change because they've already announced they're going to federalize the whole process.
Somebody else have a question that hasn't gotten a chance to ask one yet? I'm looking on both my screens. I'll ask another one then. You know, I'm remembering back to when I was a child, and we were vaccinated for polio. It was, I think, an oral vaccine that we took at school. We got it at school.
Yes. Yes.
Do you think that that's what'll happen with kids? That they'll deliver the vaccines at school?
I think that would be fantastic if it did. You know, that's not how the system has worked for childhood vaccinations. And the system for childhood vaccinations is not bad. I mean, it's, you know, it's definitely there for people who are willing to have their kids protected.
Oh, okay.
But yeah, I have no problem with that. I have no problem with it being done at the drugstores. I have no problem with it being done at stadiums, as long as they maintain the cold chain. Then and get this to people. For several decades, I was the vaccine advisor for the Kenosha Visiting Nurse Association. And like upwards of 20,000 doses of flu vaccine would go out every year over my signature. And over time, one of the things that happened was that the big pharmacy chains got into it. I'm fine with that. It gets out. As long as it gets out. It's the cold chain and administration are the important quality things, and making sure that there's adequate record keeping of who gets which shot when, because you can't mix the shots. Yeah, that's fine. If I remember correctly, the original study for, I think it was actually the polio shot in the 50s, but the vaccine was produced and then tested by the Michigan Health Department. Health departments used to have that kind of capability. In 1947, the last known person in the United States with smallpox was out in the community in New York City, And the New York City Health Department vaccinated over 2 million people in the course of a couple of weeks. We don't have that capacity anymore.
Anybody else? Anything else you want to add, Steve?
This everybody should be doing their best to social distance. As a matter of fact, the recommendation is at this point, given the overwhelming volume, is to stay home. And but use the masks, do the social distancing, be as fastidious as possible about it, because we're going to need it for the foreseeable future, and certainly for at least the next several months. These are insane numbers. This is an unparalleled catastrophe in the United States and in Wisconsin and in Kenosha. And it doesn't have to be this way. And you know, I mean, we're already well past 250,000 dead. You know, the state legislature hasn't met about COVID since April.
I have a question.
Yeah.
This is Marla. Thanks for meeting with us, Stephen. I appreciate it. My question is, what do you say to the people that are afraid to get the vaccine? They want to wait until they see what the side effects are from the earlier groups.
Okay. This is why I went over in some detail about the study. Okay. Because people, I think, don't appreciate the quality of the evidence about it. Okay, this is fantastic. You know, this is good stuff. This is reliable. This is good science. There's, you know, if there's a legitimate question as far as concern about other side effects going on, except that our experience with lots and lots of other vaccines is that the overwhelming majority of vaccine adverse reactions are within the first couple of weeks. There have been now, I just saw the number, 21 episodes of anaphylaxis with the vaccine out of 19 million people who are vaccinated so far. Okay. And those are ones that are caught right away, because you sit there and wait for 15 minutes after you get the vaccine to make sure that there isn't a problem. Okay, that's you know, that's literally 1 million. That's not bad. And considering how many people are dead and in the ground from COVID, of all ages. So you know, like I say, people talk about, you know, like Fauci will talk about the science. And I think he does it that way because he's been immersed in the science all his professional life. I wanted to give you a little taste of what good science is, and as far as this is concerned. And that's a big part of my answer. Yeah, we know. And if something else pops up, there are systems for finding that out. There's the established one, you know, the VAERS, and there's an app. I got it when I got vaccinated the other week. I can find it. But they contact, you know, I'm contacted every day to check on side effects. And that goes right into the databases and the surveillance.
They do that for everyone who's vaccinated?
It's offered. You don't, you know, I had to sign up. I also signed up for the tracking app for Washington State,
Uh-huh.
which for a privacy fanatic like me is a big deal. But that's another thing about public health, which I didn't go into, is just how high the standards are for privacy in public health. And this is done right. It's possible to do it right. It's also possible to screw it up. But this is stuff that's done right.
We have another question in the chat from Mary Beth, and actually I think, Mary Beth, we already talked about this and you might have missed it. She's asking any idea when Wisconsin will distribute. Well, do you want to just repeat that?
Okay, Wisconsin is distributing. The initial allocation from last month was about 200,000 doses, which, and I'm sure, I think there's been more since then. But there are about 450,000 healthcare workers in Wisconsin. And the initial, it was the initial goal was 20 million people being vaccinated by the end of December, which has not happened. We're at 20 million, but it's a couple of more weeks, and it's an issue. But the production is ramping up, and they did a good job on that. And they started setting up the production while these were being studied, which is an unusual way to do it. So the vaccine is definitely coming. And as I said, Pfizer and Moderna say like 1 billion doses by the end of this year. And that's probably right. One of the reasons they did the mRNA vaccine is that it can scale more easily than other types. But, this vaccine, this infection is all over the world. You're going to have to argue that we're going to have to get 16 billion doses out there. Well, some of the ones tested, but 8 billion doses.
Steve, clarify what you just said.
Somebody
The mRNA vaccine can what more easily?
Okay. It scales. Okay.
Oh, scale. Yes.
Yeah.
All right.
Yeah. Okay.
I understand.
Yeah. These two vaccines are both mRNA vaccines.
Yes.
And that is a new modality and technique in vaccines, but it's working beautifully. And despite this poor, deluded pharmacist who thought it was going to, alter people's DNA, it doesn't do that. It doesn't even come close. That's just, conspiracy crackpot stuff. Unfortunately, it was somebody who actually wanted to do something based on their delusion.
All right, we have about 1 minute left. Anyone have an urgent question that they have to ask Steve before we go?
I do. I want to take the liberty of asking. I have a personal friend I'm concerned about, and I'm wondering if I could send you an email about it. If I could take that liberty. Thank you. I'm going to use the email in the membership directory.
That'll work.
Thank you.
No worries.
Well, Steve, we can't thank you enough for being our own congregational expert on this.
Well, I hope I'm getting a message across. And
you are, and I know you're not a prophet, but would you like to end on a final note of, do you want to guess when life will
I think by the second half of this year, my opinion is that we will be able to start loosening up. But that's only an opinion, and that's in advance of the facts.
That would be awesome.
Yeah.
All right. Well, thank you so much. And thanks to Gary also for your contribution.
Okay.
And great questions, everyone. Mm-hmm. Lila Tove, have a good evening and a good rest of your week, everybody.
Okadoko. Thanks.
Bye-bye.
Thank you.
Thank you.
No
Bye-bye.
problem. Happy to be of assistance.
Long, Steve. Talk to you soon.
Mm-hmm.